Welcome everyone again to the second edition of our series on deconstructing a common bile duct injury. We're blessed and happy to have Dr. Butch Rossard and Dr. Jesse Clanton and Dr. Yana Weingard with us today. And we're excited to go over the more academic aspect of common bile duct injuries. All right, so when it comes to laparoscopic cholecystectomy, I put together a few of the pearls and the tips that are incredibly important as a novice or as a young surgeon to make sure that you pay attention to in order to make this potential situation as unlikely to occur as possible. So as part of this edition of the series, the objectives are to review some of these technical principles for safety. Then we will follow that up with a classification characteristics of the injury with Dr. Rosser. And then the management of common bile duct injury with Dr. Clanton. We'll follow that up with a discussion between all the faculty. My portion is relatively simple. I can't overemphasize that you have to be demanding. You have to make sure that you ask for the things that you need in order to make it a safe operation. This isn't just the time of surgery, this starts preoperatively. So if your operating room tells you that, look, we have a surgical bed, but it's one that we can't put in Trendelenburg or reverse Trendelenburg or left and right, or it hasn't been working. You have to be a stickler and you have to demand the things that you need. Patient positioning is also extremely important, as we had discussed in the previous edition. You have to be able to get the patient in sharp reverse Trendelenburg, especially if the patient is morbidly obese and has a lot of intra-abdominal adiposity. You have to be able to get the patient left side down as needed in order to get that perfect visualization of what you need in order to make sure that you do a safe operation. The instrumentation is also extremely important. You have to make sure that you have instruments that you're used to, ones that you know that work, especially the key instruments such as the Maryland dissector or the electrocautery hook. And you have to make sure that these are well maintained and decrease the possibility of malfunctioning or even worse of an electrical injury. You've got to also ensure that the C-arm is available and radiology staff is available. These aren't things that you want to be surprised by, by hearing that, it's in another room or there's nobody to run the machine in the event that you do need intraoperative cholangiography. And in addition to that, you've got to make sure that you get the proper staffing. Not anyone that's there, to start the case and has to run out in 10 minutes and is hurrying you. But you have to have people who are there for the duration of the case, who are committed to be your support. Intraoperatively, visualization is extremely important. If you're provided with cameras that don't work, ask for new ones and ensure that the equipment is appropriately maintained so that you get that perfect visualization. Remember, with laparoscopy, you're going to lose on tactile stimulus, but also you have got to make that up with better visualization, as good as it can possibly be. Instrumentation, again, extremely important. If your Maryland dissectors are not appropriate, if they're not the kind that they have a blunt tip on them, you've got to make sure that you obtain something that can work better. Energy devices, especially hook electrocautery that you depend upon to be able to micro dissect planes of tissue, important to make sure that not only that they're up to par, but also that the installation is appropriate. If you skimp on this portion of the preparation, then what you end up doing is getting in a situation where your field may be bloody, your visualization decreases, You get overstressed by the amount of bleeding, and all those things added together is what snowballs into a potential complication. Assistance and staffing, it's important that you have a good assistant, especially for the difficult cholecystectomies, someone who's been there before, someone who isn't learning as they're doing a very difficult case. And anesthesia is extremely important to partner with to ensure the patient is appropriately paralyzed. The last thing you want to do is be poking 2-foot-long instruments in someone's abdomen when they're bucking and moving on you. And it's important that you take your time, that you have ample time in your schedule, and that at that moment in time, really, that's the most important thing that you that's on your mind that you're taking part in. If you have staff who are more interested in what's on the radio or chatting about things non-related to the case, when you're trying to do a very complex procedure, those are the things that you have to be a stickler about and demand that everyone's focus is on the patient in front of us. And also, you've got to make sure that you take your time and go through your steps. Ensure in the back of your mind, what is the critical view? What do I have to have exposed? Have I done this on this patient? Do I need to continue in order to make sure that I'm satisfied with the structures that I'm seeing in front of me? So as far as patient positioning, as far as where things are supposed to be set up, room arrangement, this is pretty standard. The classic way is for the monitors to be at the top of the bed around the anesthesiologist, while still providing ample access to the patient's head and neck. And with surgical laparoscopy towers now, that's usually not a problem. The camera and the assistant are usually on opposite sides, although sometimes you will have the assistant hold the camera from the patient's right, and the surgeon works on the patient's left side. Variations of this can sometimes lead to problems, unexpected complications, and unexpected hurdles. And the instrument table is usually at the bottom of the bed. This is the more classic placement of trocars, and the epigastric trocar. A lot of laparoscopic surgeons with extensive experience will use Palmer's point for access for every single operation. So we've deviated from this classic placement where the epigastric trocar now is in the left upper quadrant. I'll show you pictures of that in a minute. And traditionally, in the late 80s, early 90s, surgeons used to say that, just go ahead and place your trocars along what would be a cochlear incision. So in the event that you have to open, in that situation, you would just connect the trocars. And what I say, in the contemporary situation with advanced laparoscopic training and skills, when conversion is so rare, place your trocars where you need them to be, where your left and right hand can work comfortably rather than where the cochlear incision would be. For something that would occur less than 1% of the time, don't suffer and be uncomfortable ergonomically 100% of the time. So classically, there's retraction of the fundus of the gallbladder, cephalad, and inferolateral traction on Hartman's pouch. You have to be careful to not over-retract. One of the classic injuries is over-retraction, and bringing the cystic duct and the common bile duct in line and inadvertently dissecting the common bile duct. So that's an important thing to remember when you do your retraction. I always believe, and I always tell my residents, you've got to retract a few of these before you do them, because the operation is really done from the assistant side of the table, whereas the surgeon on the other one just operates the dissecting instrument and the electrocautery. And here's an example of an identified cystic duct. It's being clipped. So the classical critical view, this is one of my cases. This goes back to my early days as a surgeon, almost 15 years ago. But you can see triangle inside another triangle. The bottom base is going to be the cystic duct. The top one's going to be the cystic artery. And it's important to also ensure, as Dr. Clanton often points out in his lectures, to expose the cystic plate. And what most people say is 25 to 30% of the gallbladder should be dissected off to ensure that there's no additional structures that could potentially run back into the porta hepatis. Now, not every patient is going to be a 4 trocar cholecystectomy. Oftentimes, you may need 5. You may need some kind of additional retraction. But not every patient needs 4. And here's an example of a patient that we operated on that only required 2 trocars. So we did a 2 trocar cholecystectomy and utilized sutures and suture passers to retract the gallbladder in order to improve cosmesis. And we call this a strategic laparoscopy for improved cosmesis, and the acronym is SLIC. So at our institution, we do a lot of SLIC cholecystectomies for the appropriate patient. And I can't overemphasize how important patient selection is, not just for the SLIC cholecystectomy, but for any cholecystectomy, to ensure that the patient would potentially benefit to outweigh any risks related to the operation. So when we do strategic laparoscopy for improved cosmesis, obviously we decrease the number of trocars, but what we also do is we make sure that we never, ever let cosmesis get in the way of safety. So our number one priority always remains safety, and then we follow that up with decreased amount of incisions and pain and improved cosmesis in patients who are appropriate for this procedure. And if you want to see who that would be, this is a publication that we had in 2011, where we realized that with advanced laparoscopic skills, when you do complex procedures, you can certainly decrease the amount of incisions and improve the cosmesis in patients who would be good candidates for that. So classically, a 4 trocar multi-port placement, you can see that in figure A there. This is from the same article, and rather figure B. And for the SLIC cholecystectomy, we utilize sutures and needlescopic suture passers in the other two trocars on the patient's far right. So with that, those are the things that you have. I'm going to conclude those by saying those are the things that you have to do in order to ensure the safety of your patient. Remember, you're the ultimate advocate for the patient. They're asleep. They're counting on you 100% to ensure their safety. And you've got to be the captain of the ship and be demanding about the things that you need to make sure that the patient gets that ideal type of care every single time.
Comment. That was great, Dr. Dan, and I absolutely agree with everything you said, and I think you emphasized a lot of very important points there. I will give a plug to you that I think I learned from you the cholecystectomy using Palmer's point instead of that subxiphoid trocar location, and I've never gone back. And I use it now, and I used it, and I showed my attendings in fellowship even, and it's a lot more ergonomic, as opposed to trying to go straight down on top of the critical view of safety. You're almost like driving like a stick shift sometimes when you're using that subxiphoid, where it's a lot more ergonomic. And I will say I had the opportunity to write the chapter for cholecystectomy in Bloomgart's textbook of advanced hepatobiliary pancreatic surgery. And I mentioned that technique. So now it's even in Bloomgart's as a description of an accepted common way of doing, laparoscopic cholecystectomy with that paper that you showed quoted and referenced.
That's great. Well, thank you, Jesse. So, I'm going to add to that by saying absolutely. And when you work laparoscopically from an ergonomic standpoint, and Butch can tell us a lot more about this. He's done a lot of work in this domain. But having your right hand not come from the top and come from where it's ergonomically natural really makes a difference in the fine dissection. And the other thing that, please let me know how you guys feel about this, but I always tell the residents early on, they always come in expecting to do the dissection and to hold the camera with your left hand. And I tell them, you can do this until you tell me you're ready to be a laparoscopic surgeon and work two-handed. There is no advanced laparoscopic procedure where you hold your own camera. So I tell them, look, I'll hold your camera from the assistant side. I'll do the fundus retraction, but I want you to work two-handed as much as possible. A lot of times it's only possible as they get into their senior years of residency and have developed those skills. But the common reproducible procedure is where you really want to practice, so you can do a laparoscopic adrenalectomy, so you can do a splenectomy, a gastric bypass, a colectomy, a liver resection, and so on. So Jesse and Butch, I'd really like to hear what you guys have to say about that.
Well, yeah, I want to go back and tag team on what Jesse alluded to, and that is ergonomics. And then I'd like to connect the dots on what you alluded to. As far as I'm concerned, there's no great one-armed laparoscopic surgeons on the planet. And you have to practice like you got to play, not today, but tomorrow. So you have to be able to mature, capability with both hands. And in Top Gun, if you look at our data going back to the early days, we found out to be able to execute intracorporeal suturing and advanced techniques, your left hand or non-dominant hand had to do just as much work as your dominant hand. And as you said, Adrian, there's no place for a surgeon holding the camera. But I also want to go into the ergonomic part of this. In 1995, we actually produced the world's first interactive CD-ROM with video game play on laparoscopic cholecystectomy. And we debuted what I call my solo surgeon technique. And I want to go back, we moved all of our ports to be more ergonomic. And we chose Palmer's point, just like you did. But what we did with the mid-clavicular point is we moved it to the lateral edge of the left rectus muscle. So therefore, I like the surgeon to be in control of everything. And you're right, the way yours is set up, the residents learn how to expose first. But for me, we train ours a little bit differently. We basically will put them, they have to get their skills up to be ready to go into pilot sleep. And we have a solo surgeon technique that we debuted back in '95, where the surgeon is sitting down, and I got this from my European experience, both at the University of Paris and other places in Europe. Even with open surgeries, they sit down. And so, and you can look at some of our ergonomic papers that we've written. And I want you to know that we believe that this is the way to lead to having better preparation to move on. Now, let me tell you, we actually used a rubber band as our assistance on the dome of the gallbladder. The surgeon sits down, and we debuted this on the Discovery Channel, and that won a Telecommunication Academy Award on laparoscopic cholecystectomy. So I want to tell you that Palmer's point for me has been a great asset, and it led to actually maturing a more ergonomic pattern, which we proved in Operation Iron Hand when I was at Yale, where we wired the surgeons. We didn't wire them. We had wireless ergonomic data flowing to the computer, and this particular technique was much more ergonomic. And we can share with you those papers. So Palmer's point is excellent. And remember, you're setting yourselves up for advanced procedures. And for me, our big campaign, Adrian and Jesse, is setting people up to be able to do laparoscopic common bile duct explorations.